Hello, doctors and friends. Today we are from the SGD B10 group. We are going to present about our student project with the title Novel Treatment and Management of Immune Thrombocytopenia Purpura. And these are the list of the members of our SGD B10 group. My name is Nadia Ernestin and the last three digits of my student number are 155. And now I'm going to present about the background of our student project. So immune thrombocythemia purpura is an autoimmune condition characterized by low platelet counts resulting from antiplatelet autoantibodies. Symptoms include a diminished platelet count, purpura, and also hemorrhagic episodes. The condition primarily affects females of childbearing age and adults over 60, with 2 to 10 cases per 100,000 adults diagnosed annually. While ITP patients are asymptomatic, some may experience mild bleeding and fatigue, with severe cases posing an elevated risk of bruising and spontaneous bleedings. Extensive research has highlighted the significant impact of ITP on affected individuals. The student project aims to contribute to the understanding of ITP. Focusing on treatment and management, it seeks to raise awareness among healthcare professionals, policymakers, and other general public about effective approaches to address immune thrombocytopenia purpura.
Okay, thank you for the opportunity. My name is Valentino with digital number is 116, and I will explain about problem formulation and then purpose and benefit. So the problem foundation of the student project first is what is the definition and nomenclature of ITP, and then how is the epidemiology of ITP, then what is the etiology of ITP and the pathophysiology of ITP, and then how to diagnose ITP and how to treat and management ITP, and also what is the differential diagnosis of ITP. And then for on the purpose, general purpose, to know the general information and novel treatment and also management of ITP. For the specific purpose, first is to understand the definition and nomenclature of ITP, and then understanding the epidemiology of ITP, and then understanding the etiology and pathophysiology of ITP, then explaining how to diagnose of ITP, and then explain how to treat and management ITP, and understanding the differential diagnosis of ITP. And also for the benefit of the student project is to enhance knowledge about the general information about treatment and management of ITP. And the student project will also help undergraduate students learn more about the clinical skills needed to become medical professional. And we hope the student project will contribute to the science of the future. Thank you.
Thank you so much for the opportunity. First of all, let me introduce myself. My name is Rahel Manurung, with the last digit to my student ID 030. So in this video, I'm going to tell about the definitions and also the nomenclature of the immune thrombocytopenia purpura. So immune thrombocytopenia purpura is actually a isolated thrombocytopenia, which is manifested by the purpura and also hemorrhagic incidents that mediated by the antiplatelet antibodies that accelerate the destructions of platelet. Previously, the term of ITP led to the idiopathic thrombocytopenia purpura, but the term is not longer used because the etiology has been identified, which is the dysregulations of the immune system. And also the term of purpura has been misled since most of the one-third newly diagnosed patient with ITP has a low platelet count without bleeding. So in conclusions, the abbreviations of ITP refers to the immune thrombocytopenia. That's all for me. Thank you.
Hello, my name is Natasha Putri with last digit of my student number 083. Now I'll explain about epidemiology of immune thrombocytopenia purpura. The incidence rates of acute ITP in children and adults range from 1.1 to 5.8 and 1.6 to 3.9 per 100,000 persons per year, respectively. Greater incidence among youngsters occur in spring and early summer following viral infection. Meanwhile, greater estrogen level promoting autoimmune influencing the ITP incidence on adult, especially on female. On the other hand, chronic ITP more common in adult with frequency 12 per 100,000 cases, increasing with age but have no dominating gender. Approximately 20% of ITP cases are secondary, which means the rest mostly are primary. Secondary ITP associated with underlying disorders such as SLE in children and lymphoid disease in adults. That's all from me. Thank you.
Etiology of immune thrombocytopenia purpura. Immune thrombocytopenia purpura can be primary or secondary. 80% of ITP is primary, which is caused by diminishing of immune tolerance towards thrombocyte, resulting in an autoimmune response. Secondary ITP, with 20% of cases, is caused by another disease, such as autoimmune diseases, virus infections, and recent reports of severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. Pathophysiology of ITP begins with peripheral destruction of platelets in the blood. This is done by antibody binding that leads to activation of classical complement pathway and formation of membrane attack complex. Meanwhile, in the spleen, macrophages phagocytose platelets, which are labeled by the complement pathway, thus become antigen-presenting cells that stimulate CD4 T cells. Stimulated CD4 T cells then induce proliferation and differentiation of B cells that further increase antiplatelet antibody production. Antiplatelet antibodies trigger removal of platelets and production of thrombopoietin by hepatocytes. While thrombopoietin is a growth factor for megakaryocytes, megakaryocytes in the bone marrow are diminishing due to binding of antiplatelet antibodies. Overall, ITP is caused by loss of tolerance and the deficiency of T regulators throughout the body.
Good morning, doctor. Good morning, everyone. My name is Kadek Asri Bintari with the last 3 digits of my student number R063. Today, I would like to present about the anamnesis, history taking, and clinical manifestation of immune thrombocytopenic purpura. The first one is anamnesis and history taking. History taking in cases of patient with ITP is done with more emphasis on secondary causes of the patient's bleeding, because many cases of ITP are preceded by other causes. In addition, good history taking based on the Sacred 7 and Fundamental 4 is also important. Examples include history taking to determine the characteristic of bleeding and the onset of bleeding experienced by the patient. Okay, the next one is clinical manifestation of immune thrombocytopenic purpura. The first one is bleeding symptoms. Patients with ITP will present with thrombocytopenia and experience symptoms such as bleeding on the mucous membranes and cutaneous bleeding. The second one is fatigue. The cause of this fatigue is often associated with thrombocytopenia and pro-inflammatory mechanisms as a result of immune dysregulation in patients with ITP. The last one is cognitive and quality of life. In patients with chronic ITP, there are cognitive symptoms and impaired health-related quality of life. Negative impact on social lives and sexual lives were also experienced by the patient. Okay, that's all from me. Thank you.
Hello, my name is Lyshanda Bianca Kusuma with the last digits of student ID A025. Now I will explain about laboratory findings. The initial laboratory tests that should be conducted include a complete blood count with differential count, direct antiglobulin test, peripheral blood smear, and antiglobulin test if there is suspicion of an underlying immunodeficiency. Additional tests that may be considered for the patients include a hepatitis C test, an HIV test, and coagulation studies. In patients with immune thrombocytopenia purpura, the result of the complete blood count typically appear within the normal range, except for a decreased platelet count of less than 100,000 per microliter. Peripheral blood smear usually shows a normal appearance of both white blood cell and red blood cell, a decrease in the number of platelets and the absence of blood cells. Additionally, the peripheral blood smear might indicate an increase in platelet size. Any unusual findings in the peripheral blood smear could indicate that the thrombocytopenia is caused by other underlying conditions. Bone marrow aspiration is seldom necessary and rarely done in patients. However, it may be considered if there are a sign of malignancy or if the patient is unresponsive to treatment. Thank you, and next slide.
My name is Dewa Angelica Utami with my last digit of my name is 098. So I will explain about the initial treatment of ITP. So the first line treatment for ITP is prednisone 1 mg per kilogram per day for 2 weeks, slowly tempered and interrupt after 6 until 8 weeks. Or pulse high dose dexamethasone 40 mg per kilogram per day for 4 weeks. And then IVIG may also be used as initial treatment in patients with ITP to rapidly increase platelet counts. Severity of bleeding rather than platelet count may be indicated to initiate the IVIG therapy. That's all from me. Thank you.
Greetings, my name is Hana Clara Stanadin, and my 3 last digit number of student ID number is 236. And now I'm going to talk about the novel tyrosine kinase inhibitors effectiveness. After analysis in many inhibitors such as rizobrutinib oral, orelabrutinib, zabrutinib, baricitinib, SKIO703, and HMPL523, the result was obtained that fostamatinib and HMPL523 are the most effective inhibitors for severe resistant ITP patients that diagnosed with immune thrombocytopenia purpura. The study result of fostamatinib and HMPL523 says that fostamatinib and HMPL523 is safer and well tolerated to use for the severe patient. Fostamatinib itself was able to produce many response to patient that was not responding to TPO therapy, rituximab, and splenectomy. Compared to older patient, younger patient was able to get more response because of the higher platelet count. Patients that have hypertension and gastrointestinal adverse effect get more sufficient medical management with anti-motility and anti-hypersensitive. Although fostamatinib is more expensive compared to other oral agent, patients preferred fostamatinib because of the effectiveness. Other than fostamatinib, HMPL523 is also effective because it was well tolerated with no serious adverse effect. Therefore, fostamatinib and HMPL523 was chosen to be the most effective inhibitors.
Okay, in this section we will talk about treatment and management of immune thrombocytopenia purpura. Before that, let me introduce myself. My name is G Mahapraja Divasta with my 3 last ID number 02H. Now is the novel anti-CD40 ligand antibodies. So first, in the pathophysiology of ITP, they are activated T lymphocyte cell that require soluble CD40 ligand has an antigen antibody mediator to activate B lymphocyte, so that it can produce antiplatelet antibodies and bind to GP2B or 3A receptor. It can fail the aggregation process of platelet. Now, the study has found monoclonal antibodies from anti-CD40 ligand which have modification to the FC receptor. One of it is the letolizumab. The second therapy is anti-CD38 antibodies. In ITP, plasma cell and other immune cell will express CD38 in cell surface, which will induce the production of antiplatelet antibodies. These antibodies can cause the destruction of platelets by macrophages with the process of opsonization and phagocytosis. The anti-CD38 antibodies that can be used include daratumumab and mezagitamab. These antibodies will bind to plasma cell, natural killer cell, activated T and B lymphocyte cell to inhibit the immune process that occurs due to CD38. That's all from me. Thank you.
Hello, my name is Ananta Wismaya with the last digit number of 198, and now I'm going to explain about the splenectomy management. The spleen plays a central role in pathophysiology of ITP. For decades, splenectomy was the only treatment for chronic ITP. Additionally, there is some complication regarding splenectomy, such as the risk of developing subphrenic abscess, which is more prominent in patients with ITP. There is also increased risk of severe infection from bacteria such as Streptococcus pneumoniae. There are various treatments before and after spleen removal aimed at minimizing post-splenectomy complications. Prior to the procedure, it is essential to do vaccination. And for post-splenectomy management includes the use of prophylactic antibiotics until the infection risk decreases. Additionally, suggesting regular re-vaccination every 5 years. Given the complexity of splenectomy and its associated risks, intraoperative and post-operative care is key for minimizing complications.
Let me introduce myself. My name is Fitri Atata Ginting with the last 3 digit number 140, and I will be explaining about the differential diagnosis of immune thrombocytopenic purpura. First is myelodysplasia syndrome, which lab finding shows dysplastic cells and blasts in peripheral blood film, and this actually underlines the diagnosis of MDS, but cytogenetics testing is also needed to confirm. Next is thrombotic angiopathy, such as thrombocytopenic purpura and hemolytic uremic syndrome. And hemolytic uremic syndrome usually manifests along with diarrhea in children, and lab finding shows negative direct antiglobulin tests and schistocytes in peripheral blood film. Next is DIC, in which it manifests as petechia, ecchymosis, gangrene, acrocyanosis, and other ischemic findings in other organs. But the pathophysiology of DIC and ITP is very different, and the DIC involves coagulopathy. Lastly, pseudothrombocytopenia, which is caused by agglutination of platelets and mistaken as thrombocytopenia in automatic cell counting. And there's no clinical manifestation or whatsoever, but manual count or count in citrate is needed to eliminate the possibilities. That's it for me. Thank you.
Hello, my name is Praditia Putri. My last 3 digit of my student number is 067, and today I'm going to explain about the summary of the student project. So, immune thrombocytopenia purpura, commonly known as ITP, is a condition associated with an autoimmune response by antiplatelet autoantibodies that accelerates the destruction of the platelets. This illness usually characterized by low platelet count that are most asymptomatic and associated with underlying disease or secondary ITP. So the primary without the underlying disease. On top of it, ITP has a significant impact on infected individuals because most individuals that are affected by ITP are commonly diagnosed with ITP often come with a viral infection. Secondary causes of ITP can be drug exposure, family history of platelet and bleeding disorder, also hematology disease, or even liver disease. Clinical manifestations of ITP are bleeding, fatigue, cognitive impairment, and negative impacts of quality of life, so that it makes sense that this ITP has a significant impact on individuals that affected with ITP. The treatment of this condition will be done with corticosteroid for the patient without contraindications, and for the other treatment option that can be tyrosine kinase inhibitor, novel anti-CD40 ligand, and anti-CD38, novel splenectomy, and the goals of this treatment itself is to prevent bleeding and keep the platelet count at a safe level to avoid bleeding. That's all. Thank you.